Rahul Dhavalia. I'm a second year surgical resident. I'm going to present a surgical audit on a closed loop obstruction in left colonic malignancy. 64-year-old male presented to the emergency and attended by CMO and a physician. Opinion was taken with chief complaint of pain in left lower abdomen since 3 months, which has aggravated in last 7 days and now has become generalized, which is dull aching, continuous and non-radiating. Also gives history of vomiting with the patient has its on examination patient vitals has hypotension. So for this patient was admitted under medicine department, and on next day patient was referred to general surgery department for complaint of pain in left lower abdomen with associated distension since 2 days, and patient has multiple episodes of vomiting 7 days back following meals which is containing food particles without blood or greenish discoloration. So there is history of constipation and weight loss. There is no history of fever, loss of appetite, passage of blood or mucus while passing stools. While patient last passed flatus and stool on the day of presentation, and patient was admitted for similar complaints at Gomtipur Hospital for similar complaints 7 days back and referred to civil Ahmedabad for further management. Uh, so findings of registrar. Patient's abdomen was distended and there was a generalized tenderness present with guarding and rigidity in left hypochondrium and left lumbar region. And there was an ill-defined large palpable lump in left hypochondrium and left lumbar region. And hyperperistaltic bowel sound were present on auscultation. Patient's chest X-ray was done, which was showing
chest and abdomen, only a few air fluid layers, nothing more.
A few gaseous bowel loops.
Okay.
Large bowel loop were visible. So these findings were informed by the registrar to the consultant over the phone and was asked to take transfer. So abdominal X-ray was erect abdominal X-ray was done, which were showing multiple air fluid levels. Which
this was done by us.
Yes, sir.
Okay.
There were multiple air fluid levels with dilated large bowel loops, and with there was a distal colon cutoff was present.
Okay. What about vomiting? Was it there still? Rahul? Hello.
Sir.
Was vomiting there when we saw the patient? Did we put in a Ryle's tube or anything?
Yes, sir. We put a Ryle's tube, but there was no complaint of vomiting. On putting RT, there was 10 cc gastric aspirate came. Nothing else came out.
Okay.
The patient had vomiting last episode 7 days back, for which patient was treated at Gomtipur Hospital, and then after that patient was NBM since 7 days.
Oh. Okay.
So on history and examination, there were 4 possible diagnoses. First diagnosis was the large bowel malignancy with or either without perforation. And second would be diverticulitis. And third was ischemic colitis. And fourth could be colitis.
So some kind of infective pathology or ischemic pathology or maybe even malignancy. Right.
Further investigation, routine investigations were done. So this was the blood profile on the day of presentation. Patient hemoglobin was 6.20 and the specific finding were patient's serum TSH were 40. Patient was known case of hypothyroidism and was on tablet thyroxine for it.
Okay. Yes. But still the TSH was 40.
Yes, sir.
Okay. Okay. Okay.
Ultrasound examination was done, which was suggestive of there was a descending colon, sigmoid colon.
Rahul, yes. Go back.
Yes, sir.
Still one back. So why did you put all these diagnoses?
So first I
Explain
kept
which was first diagnosis and reason for putting diagnosis.
So first, I kept large bowel malignancy with or without perforation was because the clinical presentation was mainly suggestive of obstruction, but because on examination, patient had a large palpable lump with guarding over the left lumbar region and hypochondrium, so it could be perforated mostly. So that's why I kept my first diagnosis as large bowel malignancy with or without perforation.
Why not perforated diverticulitis?
Could be there, sir.
Is,
The patient didn't give history of passage of mucus also in stool. So, hello.
Yes.
Third, ischemic colitis can also present with similar complaints, but on examination there was no blood or melena in digital per rectal examination, which is generally a common clinical finding in ischemic colitis.
Rahul, go back to X-ray standing. What does it show? Sorry, I am in a car, so that is a problem.
yeah, sir.
So it shows multiple air fluid levels.
What do you mean by multiple air fluid level? How many air fluid levels are there?
Can you count
three.
it?
I haven't counted, but more than 3 air fluid levels are.
Where are they? Where are the air fluid levels? You are
So,
showing it, but in which
yeah.
part of the bowel it is?
Bowel, yes. Which
Well,
bowel? Small bowel or large bowel? Jejunum?
The
Ileum? What?
it's a large bowel, large bowel. Small bowel loops are not visible here.
Why do you
So
say it is a large bowel? Why do you say it is a large bowel?
And because on here hostrations could be seen and peripherally placed dilated loops.
Okay. But
what
here
else?
it's more as compared to the this fluid. Will you say it is as a obstruction?
I couldn't hear your
Yes
question.
or no?
Ma'am, he couldn't get you. Please repeat your question.
So here in X-ray, you are seeing more gas as compared to fluid. Will you say it as a obstruction or paralytic ileus? Post gastroenteritis or post dilatation of the bowel, large
But,
bowel.
ma'am, on examination, paralytic.
So, Rahul, if you are getting lot of gas shadows rather than fluid levels,
Yes, sir.
especially in a patient with history of diarrhea, will it be paralytic ileus or obstruction? That's what ma'am is asking.
So, with history of, so in this patient, there's no
Diarrhea and
diarrhea.
vomiting.
The vomiting could be seen in small bowel obstruction. That is the common complaint in small bowel obstruction. But here, vomiting was not the main complaint. Distension was the complaint. And on examination also, sir, auscultatory find hyperperistaltic bowel sound was present. That are usually absent in a paralytic ileus.
Okay.
Rahul, this was the X-ray actually. First X-ray was this. Are you
No,
sure?
no, sir. This
The
no
first
second.
X-ray was this
First
one.
X-ray is this.
This is the
Which,
first X-ray.
yeah, which
So
showed
what is
only gas
difference?
shadows.
So what is difference?
Rahul, what is the difference between the two X-rays?
So over here only left sided gas, large bowel gas could be seen near the splenic flexure, and then that could be overlapped by a fundic shadow also. But on the AXR, we could see all this large and small bowel loops also. But small bowel loops were not visible because it was collapsed mostly.
Yes, so this was showing only gas shadows, right? As compared to the second shadow, the X-ray you are showing, which shows some air fluid levels, not this one.
So shall I go ahead?
No, definitely no.
Wait.
So what do you see in this? Why it is not paralytic ileus? You have not yet answered.
I couldn't.
Patient is having colitis and patient is having diarrhea. What will be the type of X-ray you want? Have you seen any patients X-ray having colitis? In which the small bowel will not be seen.
शंकर हाँ उसको रीनल कंफ्यूजन है फटाफट यूरिन में जाना चाहिए पेशेंट रीनल कंफ्यूजन है ठीक है क्या है ना बोलना कि
Please mute your audio. Who is in between? Somebody speaking. Variam, please. Variam's iPhone or
Hello.
oh, sir, that's you.
Yeah.
Sorry, somebody is okay. Sorry.
I'm listening.
Okay, fine. Go ahead, Rahul.
Yes, sir.
What will you find in X-ray of colitis?
Ma'am, आप बता दो, please.
In a patient having colitis, you will find out gaseous distension of the whole colon and not of this much part of the colon. That is more important. There may be some fluid, but a gas will be also found into the sigmoid colon and the rectal part, in pelvic part of the colon also. It is a gaseous distension into the whole colon and not the some part of the colon, right? Okay.
So here you are seeing a specifically two air fluid level, mainly one of the right side of abdomen, one on the left side of abdomen, and with a definite air fluid level. What does it mean? And hardly air fluid level in small bowel.
Yes.
What is significance of that's what I am asking.
That the ileocecal valve is competent, and this might be a large bowel obstruction, mostly closed loop obstruction.
Is your heading, but what first thing is, what does this suggest? These two air fluid level you have shown, what does it suggest? What does it mean?
So which part of the bowel is distended first?
Proximal to the obstruction, so that is a descending colon, then transverse colon, and this one is ascending colon.
See, there are two air fluid level, one on the right, one on the left. So which is involved? Now tell me.
Cecum is
left is due to
descending colon, proximal part.
Descending? No.
Splenic flexure.
What comes there? What comes there? It is a transverse colon. You can say it is going medially. So that is the air fluid level in transverse colon going up to hepatic flexor, something like that. It is
oblique and going transversely. Oblique. It is oblique and transversely, not going straightway downwards. If it is straightway downwards, it is descending colon. Okay.
Will be in the flank. So these are the two air fluid levels suggest that obstruction is somewhere in descending colon, because you can see the sigmoid colon is not distended and the transverse colon is distended. So this X-ray suggests there is something wrong between transverse colon and sigmoid colon, right? So that is the importance of this X-ray you should understand. And you can see that there is a right side dilated loop. What does it suggest?
Cecal valve is competent, and the ascending colon is also dilated.
So what is meaning of that?
It's a closed loop obstruction.
You are hell-bent on cold. That suggests that ileocecal valve is probably competent, right? You cannot stamp it as a probably ileocecal valve is competent. That suggests it might be a closed loop obstruction. So for the residents' benefit, tell what is closed loop obstruction.
So closed loop obstruction is when there is some obstructing pathology, organic pathology in the any part of the colon with ileocecal valve competent. So there's only dilatation of the proximal part of the colon, proximal to pathology, part of colon proximal to pathology.
So what is the definition of closed loop? Closed loop. Definition. By definition, closed loop obstruction. So whenever there is an obstruction at both the end, it is known as a closed loop obstruction. It's not necessary into the colon only. It can be into the small bowel when there is a volvulus also. So there should be a both ends should be obstructed. So it is a closed loop by definition. Okay.
So you understand, closed loop is, this is not the only closed loop. Closed loop is the intermoving bowel closed on both ends. So what is significance of that? If you see this X-ray, what will you think? Are you there, Rahul?
Yes, sir.
I think he has gone.
Rahul, no. Hello, Rahul.
બહુ પૂછ્યું હવે કે હું ભાગું.
Rahul.
Sir, I'm here. Hello.
Okay. Did you get the point?
Yes, sir.
What sir is asking?
Yes, sir.
Did you get the question?
So what does it suggest? Understand
what
this
is-
point. If it is a colitis, as madam has said, there will be gas filled, whole colon will be gas filled. If it is a paralytic ileus, there will be a gas in the small bowel also. When you say air fluid level and the amount of gas as well as fluid, it suggests that very minimum of no gas or fluid going further. So it suggests obstructive pathology. So it rules out diverticulitis early and colitis, right? So it suggests either benign stricture, volvulus or malignancy. Can this be a volvulus?
Rahul, respond. Now, Rahul, you have a problem with your audio?
Oh, sir, I can hear you, sir.
So respond, yaar.
Yes, sir.
So what do you see in volvulus? You must have seen a case in volvulus. What type of X-rays do you see? What type of volvulus did you see?
The coffee bean appearance is commonly seen on the X-ray of a sigmoid volvulus.
छोटा coffee bean के बड़ा coffee bean?
Lakshman, would you
Yes,
like to
sir.
say something, please?
Can you create closed loop obstruction?
Rahul,
Yes, sir.
Dr. Lakshman is asking a question.
Can it be iatrogenic?
Can be if we close the two ends.
Hello?
Simple क्या होता है आप लेप्रोटोमी करते हो तो when you are doing a resection
Adhesions.
anastomosis or something?
The adhesions, mostly.
Hello?
The adhesion
sir.
might cause
Suppose you do end colossus.
I can't hear you.
Hello?
Yeah,
Yes.
sorry, I lost you. Rahul, could you hear him?
yes, sir.
Okay.
You got the point?
I didn't get your question.
Suppose this patient is having intestinal obstruction and you want to relieve it, you make a colostomy. What type of colostomy will you make? Got it?
If we do resection and anastomosis, then we'll do.
I'm talking about colostomy only, not resection and osmosis. In this patient is sick. You cannot do resection and osmosis, and you want to do a colostomy only, or your sir asked you to make colostomy. What type of colostomy will you make? End colostomy or loop colostomy?
Transverse colostomy will do.
And या loop, sir ने क्या पूछा यार? तुम जो and या loop, what is the difference?
The loop colostomy.
Okay, why? Why not end?
Because
क्या होगा अगर आपने इसमें एंड कोलोस्टोमी कर दी तो?
the here distal part, that the distal loop will
Yes.
be difficult to be
नहीं बंद कर दिया और see you have brought out a transverse colostomy या ileostomy बाहर निकाला है and there is a mass in the distal colon. What will happen?
Closed loop obstruction.
The same. Simple. So this is the clinical implication basically. In intestinal obstruction, if you do colostomy or ileostomy, it has to be a loop rather than end. So there is not a closed loop that will create a distal closed loop obstruction. Okay, go ahead.
So what was the sonography again?
the sonography was suggestive of left sided colitis. Hello?
अरे यार, sorry, I am not getting your audio.
The USG was suggestive of left sided colitis mainly. There were no other specific findings.
Okay. So that was an issue. Okay, and it was all inflamed and bowel was thickened. Okay, fine. So what did we do?
We could have done either colonoscopy.
Nina ma'am, what would you like to do?
I want to ask one question.
Yes, sir. Yes,
Yeah.
sir. Please.
Sure.
Why do you want to go for ultrasonography in a patient whom you are suspecting intestinal obstruction? Because there is a lot of gases, you will not be assess the abdomen.
Rahul, question for you. As a PG student of Civil Hospital Ahmedabad.
A lump palpable in the left hypochondrium and lumbar region.
So what do you want to see in a patient having obstruction in USA?
Organ of origin.
What will you see in USA?
There will be a grossly dilated bowel loops with to and fro movements.
That is also, you are clinically also seeing that. What
If there
else?
is any organic pathology which could be seen, like in right-sided malignancy, there would be a mass in USG that is visible, but in left-sided malignancy, mostly it is a constricting type. So USG not conclusive.
Then why did you order?
So pseudo kidney lesion क्या होता है? Rahul,
Yes, sir.
what is a pseudo kidney lesion on sonography?
Kidney lesion or target sign that is suggestive of obstruction.
So Dr. Khiria's question is, why did you go for USG?
Okay,
Basically,
one is
because
to assess the local pathology.
yes, and
It's a-
it is the easiest modality of assessment when it comes to civil hospital. Low, almost no cost and no irradiation, and
Yes.
immediately it gives you results.
Easily
when
available. That is one
yes,
thing.
so whenever you want to have an overview of abdomen, you always go for, so that you know what is a specific thing you want to check. Even if you want to go for a CT abdomen, you would like to know what you are looking at.
Yes, sir.
So
Right,
it will
Rahul?
give you information about the liver, kidney, and free fluid available there, cystic or solid lesion. Because as you mentioned, there is a mass or lump available or palpable in the left lumbar region. With sonography, you can characterize it. But unfortunately, the findings were not correlating with the clinical finding. They said only just non-specific.
Yes, sir.
Okay.
Okay. So what should we go for, ma'am? Ma'am, what is your suggestion, Nina, ma'am?
CCT abdomen should be done first. Rahul, what will you do first? CCT or colonoscopy?
And if the patient is stable, then we'll go for CECT. And if the patient is
I am asking for your patient.
For CCT, colonoscopy during emergency doesn't have any role.
Yes. But if it is acute obstruction, will you do colonoscopy? As you say, it is acute obstruction.
No, ma'am. We'll go for exploration. That's it.
So
Why
directly
suppose,
without
hello,
diagnosis, you will go for
Yeah.
exploration.
hello.
Yeah, Dr. Lakshman. Yes, sir.
So you did the CT scan. It shows intestinal obstruction, and patient is 85-year-old. Will you go for colonoscopy now?
Rahul sir has given you a situation.
So for palliative stenting, palliative stenting to relieve obstruction could be done, but it doesn't have any benefit even after
Why?
that. So,
You can tide over the crisis without finding. Hello.
yes,
That is theoretical. At least you can tide over the crisis by doing colonoscopy and stenting.
but during emergency condition, in emergency presentation, for the prerequisite for colonoscopy like bowel preparation or other things are not there, and colonoscopy will help in decompression or for biopsy, but it will not give you the definitive result.
Why
So
not
in the
definitive?
patient having, yes, continue. Dr. Lakshman, continue.
Why it is not definitive? If you can stent or negotiate the stricture and put a stent, why not?
Rahul, that is why sir told a 85-year-old man. You get the point? You were given a situation for that.
Yes.
Mostly the cause of obstruction could be malignancy in such a age
Yes.
group, so that
Agreed.
could not be relieved.
So that is the point, is to just tide over the crisis. Say you buy 1 or 2 days till you stabilize the patient for general anesthesia. You are right, but still the thing is that if at all it is possible, of course the chance of migration migration of the stent and everything is there, but still it's a good chance if you can do it for a say 3 or 4 days or 5 days.
Yeah, it's a high risk patient. If you do not want to go emergency surgery in a patient where outcome is not guaranteed, then it is better to go for a lesser invasive or a procedure which can partly relieve at least.
Understand, Rahul? I think we have discussed this part in our last lecture also.
Okay.
Right. So CECT is definitely a better option, unless and until, as Dr. Lakshman Kiria already suggested, that colonoscopy would be good if we are planning a stenting or the patient is old enough for any other intervention immediately. Right. Okay.
Why not straightway exploration? Did you discuss?
Na sahib nathi baki.
Why
We
not
will discuss.
straightway exploration?
Yes, we will discuss definitely.
Should have gone for straightway exploration because the presentation patient had localized guarding tenderness, which was suggestive of mostly a perforation with malignancy.
So you will go for a straightway exploration?
The patient was unstable, then I would have.
What do you mean by unstable?
Sepsis.
What was the presentation of the patient?
On presentation had generalized distension with lump palpable and tenderness. And but on routine investigation, patient was not in sepsis. So
Was there any shock on admission?
patient had a hypotension as, but otherwise patient was vitally stable.
What is shock? Hypotension and shock, what is the difference?
When systolic blood pressure is below 90 mm of Hg.
And
the tissue
what about
perfusion
pulse?
is So patient pulse was 90 per minute.
So ma'am asked you whether there is any shock sign or not. You said there was hypotension.
The patient was not in shock at the time of presentation.
Okay.
So these are two things. One patient, when patient presented, patient is presenting with the shock, or patient is having some septicemia. In that case, patient is having restricted urine output. So patient is going towards the renal failure, and you cannot do CCT. In two conditions, you will directly go for the surgery and not send patient for any other investigation, right?
Yes, ma'am.
So did you understand what is shock? Lakshman, what do you say?
Hello?
Yes. What is your opinion? Why not straightway exploration?
If patient is stable, then better to investigate, better to prepare. All the armamentarium should be there so that you can do a definitive surgery rather than uncharted territory. If you have a map, road map, then it will be better before going into the abdomen. So if patient is stable, it is always advisable to get investigation and then plan. If patient is not stable, or it is only possible only in trauma patients where hypotension or bleeding is there, then straightway you can go inside. Otherwise, most of the patients are stable enough to investigate and you can plan the surgery beforehand.
Exactly. One more point I would like to, that is the what issue. If patient, you had yourself has answered it actually. Are you listening me? Can you hear me?
Yes, sir.
I thought you are not hearing me. So what I was saying, that means you yourself have given a point. Patient had only localized guarding. You understand? Palpable lump was there. Hypotension may be because of only the fluid was not replaced and anything. Patient may not be in a shock actually, right? So the point was that if same patient had a generalized guarding with rigidity, and patient cannot be shifted, or you are not sure that CT will change your management of exploration or not, in that rare circumstances, you should go for a direct exploration. Here, though the patient was having a possibility of perforation or maybe a obstruction, but there was a time, that difference of 8 or 10 hours on, and patient can be shifted. So it is definitely in today's scenario, as Lakshman has said, we should have more advantage of all the CT. The reason is that it may change your management also, and you can plan your surgery better way. Because in that case, by chance, if CT shows only diverticulitis, there is no evidence of growth. Do you understand? In those circumstances, yes. So CCT is relatively non-invasive. If you are suspecting it may be a perforation, you can avoid the rectal contrast. Do you understand? Or if you suspect there is an oral contrast will cause problem, you can do it. But yes, CT is indicated. Colonoscopy is a doubtful. It depends. If the patient is a very old patient,
Yeah,
and
indications are different.
Different. Do you
Indications
understand?
for colonoscopy are different.
Yes, absolutely. So yes, so on that way you should say we should go for a CCT because the patient condition was relatively stable. It was a localized disease. It will give you the idea. Suppose you do CT and you find ureter is involved. You understand? USG might have missed it. So definitely there is an indication of doing CCT unless the patient is having generalized guarding and unstable as the initially said. Lakshman, do you agree? That's what
Yes, sir.
That's what we should do. Okay, so what was the next? Now tell me.
So CT abdopelvis was done.
Was done, yes. Lakshman, incidentally, this is our patient. It is actual patient. We have operated before 20 days only.
Yes.
So CT was suggestive of a lesion in a mid-descending colon, which was causing a severe luminal stenosis and gross dilatation of a transverse and ascending colon and iliac loops. The lesion was involving a length of around 60 mm with a thickness of 30 mm. And there was a large fluid collection with air pockets, which was seen adjacent to the lesion with associated large collection, which was tracking into posterior paracolic, infiltrating left posterolateral abdominal wall. And there were multiple non-enhancing hypodense lesions, which were also seen in both lobes of liver, while there was a subtle pleural effusion bilaterally, and rest of the CT was normal.
Okay.
This was the image of CT, which is showing grossly dilated colon loops with a constricting mass present in the descending colon. And this is a retroperitoneal collection, which is seen over here.
Okay, this is the one.
This is the another image axial section, which is showing a constricting mass with
Rahul, speak. Stay in one position and speak. Your voice is sometimes very loud, sometimes very. So stay in one position and speak.
Yes, sir. This is the another image which showing constricting descending colon mass with a peritoneal collection and a few air pockets over here.
Yes. So now what? Next. Yes. Now again, Lakshman, he has again put this. Now, is there any role of colonoscopy? Rahul, what do you say?
In this condition, colonoscopy doesn't have any role.
Why?
As it is a organic pathology with mid-descending colon mass, so this will not give the definitive cure.
No, remember, colonoscopy is never for cure. Forget about cure. We are not talking of cure. There is no question
Why
of cure.
do you mix the words?
Ah. The surgeons will become superfluous then.
Yes.
So we are not talking of cure. We are talking one of the, as we have discussed previously also, it may be an investigative tool or a palliative tool also.
Palliative, yes.
So that is what we are discussing. And what we have done is a different thing. We want to judge, could we have done something different? That is the only issue. Or the one thing actually I was in car, so I could not discuss. That was a very important message actually I wanted to give to the all residents. So any patient admitted in medicine having a lump is a surgical case.
This is what
Yes.
I asked him, why this patient straight away go to medical emergency? Why not to surgeon?
Nobody had actually found the lump.
Okay.
So that was the issue I say. Per abdomen examination is very important. They had admitted the patient with colitis diagnosis and they were treating colitis, but they felt that there is something wrong. So actually they referred patient for a pain in abdomen and not for the lump. That's what we want to tell. So any reference to surgical side, you should very detailed examination of abdomen is important. Second point which I wanted to emphasize upon was the first X-ray. If you, as a surgical registrar, if you had seen that X-ray, should immediately ring the bell, there is something wrong. Do you understand? It is not an X-ray of colitis. It is a definitely X-ray. Forget about closed loop. Closed loop, don't give that much importance to closed loop. It is definitely an X-ray of at least a subacute obstruction and need to evaluate further. So the first point in this that it was whose fault we don't know, but patient was unfortunately admitted in medical side. So it is a pure surgical case, but this can happen. The problem, what happens, Lakshman, once patient is admitted, everybody else feels it is not my cup of tea.
True.
So even surgery resident will go and say, okay, continue treatment, add metrogil, and we will review the case. It should never be that. Even a guarding, slightest, because this was a mask, but it may not be mask. Remember, ischemic colitis is one of the other conditions which should be kept in our mind. And the patient may present like this only. There might be a multiple small ischemic patch covered by omentum or collection and will exactly present like this. So that's why if you find guarding or a lump formation, it's a surgical case. This is for all residents. Lakshman, would you like to add anything to that? That is
Yes.
the point we should always make, that if there is a lump, if there is a guarding, it is a surgery.
And I see what mind knows.
Yes, exactly. There is a physician, they will never, I
Yes.
don't know, they will always see liver only. I think so. This is what happens. So the X-ray and lump, those two were the very important findings initially, right? So don't concentrate on hypotension. Do not concentrate on diarrhea or vomiting. The patient's X-ray was very typical, as well as there was a lump with guarding. You understand? It is not necessary it would have been a malignancy, but it is definitely was not colitis. It might be ischemic colitis. It's again a surgical condition. You should understand. Diverticulitis, uncommon in descending colon, but can also be possible. What was the first USG finding? This was the USG done by surgeon. Did you have a USG finding when patient was admitted in medicine ward? There was a USG done then. Was it?
So this is the first USG.
Look, this is the difference. You can see the difference between actually referred by surgeon and referred by physician, and importance of CT. This will give you the idea. So ultrasonography looks very, it can be colitis, it can be this. There was no evidence of definite mass seen. So understand, the clinical evidence is more important than USG as far as we are concerned. Okay, so now the colonoscopy is necessary or not?
In emergency condition, colonoscopy will not be helpful.
No, yeah, don't answer. You yourself, what are the CT findings? Go back. So what does it show?
Descending colon mass with gross
So
dilatation.
suppose you do colonoscopy, will this abscess go away? Can you stand this?
Okay, we'll reframe the question.
Okay.
What are the complications of colonoscopy?
Exactly. Yes, great.
Perforation and bleeding.
Stop there.
So obviously, so again, you should answer. So our decision to do CECT first was justified. In an emergency condition, unstable patient, probably perforation, it is preferred that you should first go for CECT and then decide. Suppose the same patient is planned patient having the growth without perforation, yes, then there is a role of colonoscopy. Do you understand? So this
And
is
without obstruction.
Without acute obstruction, then there is a role of colonoscopy, because then you can have because you cannot wait, because main reason for colonoscopy would be to take a biopsy. In such patient, you cannot wait till the biopsy comes. So it is not an indication of doing colonoscopy. So
because
CECT,
it will not affect your management.
Exactly. So CECT, what I want to give message is, in such condition, CECT has definite advantage over colonoscopy in emergency situation. This is what the actual message I want to give. First is, I have already said, lump guarding always surgery, surgical case. And this is the another message. There is a definitely role of CECT in practically all such patients, right? Unless the diagnosis is very clear or patient is having a definite obstruction of small bowel where it may not be much of use in certain cases. Okay. And tumor marker, I think there is no need to discuss. It is just for the completing the list, because we never think of that in such condition, because it does not have a diagnostic value. So what is difference between diagnostic value and prognostic value?
Rahul.
Regarding tumor markers, carcinoembryonic antigen is the one which is used, and it is not. It can be used for follow-up only. Like normally, less than 5 nanogram is the value, but if it is more than 20, then it is highly suspicious of malignancy. And for follow-up after the resection, follow-up markers can be used. That recurrence for recurrence.
You don't answer me. It has what is doing by diagnostic value and prognostic value?
Sir, no question, Samaj. What is he is asking? What is the value? What do you mean by a diagnostic test, and what do you mean by a prognostic test?
The diagnostic test.
So half of the answer you have said is for the diagnosis.
Yes.
Half of the answer initially what you said is the diagnosis.
So understand,
rest of the answer is for the prognosis, right?
So understand, the elevated level of CA is suggestive, not definitive. One, in even such an inflammatory condition, it can be elevated. So it has no diagnostic value that it is 100% malignancy or not. But elevated CEA comes to normal or the follow-up, you have already answered. But understand here what we are for is understanding the question. So it has no diagnostic value, because suppose CA is elevated in this patient, what will you do?
It will not affect the management.
Exactly. That is the point. It is not going to change your management, right? It is done for some other purpose. Okay. So that is, though all these two are not to be done, right? So what did you do next?
We straightway went for exploration.
Yes.
So introp 100 ml was 100 ml of purine fluid was drained. Small bowel loop was dilated, while transverse colon, cecum, ascending colon, they were grossly dilated. There was a 5 by 5 centimeter hard mass which was seen at proximal part of descending colon, and on further dissection there was 1 by 1 centimeter perforation which was found on the anti-mesenteric surface, which was sloughed out. Then there was also a sloughed out segment on the posterior wall of the descending colon, which was communicating with this retroperitoneal abscess in front of psoas major muscle. And there were few deposits also present over the girota fascia of left kidney. So these were the introp findings.
What about liver?
The liver was normal.
Ah. On CT scan, you said there are multiple bilobar metastases.
But
Okay.
on introp,
Yes, that is a good point.
there were CT was suggestive in the indeterminate lesions, but introp liver was normal.
Yes, so
Okay.
that Rahul may not be able to say, because the operating surgeon is, I don't know he's there. I don't think he's there. So the point was that per operative it was. So what may be this? Lakshman, would you like to ask that?
Yes, sir.
Probably, what was that these lesions were? I think.
What were these lesions?
What the CT people have shown. Possible. Rahul?
See, the possibility of differential of metastasis will be the hemangioma, small cysts, or
I think small multiple abscesses was more likely. That is what I think portal pioneer, right? Suppose, Rahul, this was the decision taken. Suppose there would have been a liver showed a multiple metastasis. Then what would it change your management? That's what actually Lakshman is interested in.
With the liver metastasis, so it wouldn't have changed my management. So
Why?
because with liver metastasis, resection is also done. And so post-op chemotherapy could be given.
Okay.
5-fluorouracil and leucovorin mostly.
So
No, don't
you
go
will
to that level. Stay in the operative area.
Now there is an operating surgeon has written. You can read it. Intraoperative, no lesions were found in liver. So it is confirmed. There were no lesions in liver. Not even abscesses. Forget about this. Chemotherapy comes later on. The question you understand.
Why do you want to go for chemo?
This is do not speak of chemo just now. Yes.
Yeah, stay in the operative field.
So, should it have or not?
Sir, I couldn't hear your question.
Options do you have? Hello, can you hear?
Hello.
What options do you have in this patient?
Actually, he did not hear, Lakshman, he did not hear your question. That was the problem. So the first part was, if there would have been a metastasis, in these circumstances, what are the options available with metastasis and without metastasis? Understand? That's what I think you want to know. Lakshman, it's okay? That's what?
Okay.
Yes.
So options was we could have done resection of the mass with the double barrel exteriorization of the.
Is it possible? Is it possible in colon double barrel exteriorization? particularly with descending colon lesion.
So what other thing you can do?
That is the one thing. So here written it is, you have written it.
What is
What
the other
other
thing
thing?
possible? Can you do anything else, Rahul? After resection?
Proximal stomy.
Julie,
Good.
Julie, unmute your audio video and you answer it. You were present in operative field, so you should answer it. Julie?
Hello.
Yes.
Am I audible?
Yes,
Yeah,
you are
yeah.
audible. Also unmute, on your video.
Yes, sir.
Yes. Yes. So
Okay.
sir has asked, what are the options thought of per operative?
Intraoperatively, we discussed we might not be able to exteriorize the proximal and the distal loop since it was a descending colon malignancy and approximately 5 centimeter of margin on each side we had excised, but we did a complete transverse colon was well mobilized, so we were able to take the proximal as well as the distal loop at the same site. Stroma could be created without difficulty. If transverse colon had not been mobilized, we might have thought of doing a separate stoma, taking out proximal and distal loop from a separate site. That was another option that we discussed. Since patient's bowel was not well prepared and colon was grossly distended, doing a primary resection and anastomosis was out of question.
So that is the word of Lakshman. What she says he was able to do, that is the first. Second option is to bring out two ends at the two different places.
Yes, sir.
And third option?
What is Hartmann's?
So, if separate loop could not be brought, then we could have done Hartmann's procedure.
No, what is Hartmann? Sir is asking.
What is Hartmann?
In Hartmann's, we do end after resection of the mass. We do end colostomy and closure of the distal stump.
Actually, we did a very long, wide
Okay, that is
discussion
Hartmann.
last time in the diverticular disease. We have discussed Hartmann in very detail. So was it considered Hartmann, Julie?
In this patient, we did not consider Hartmann.
Why?
Because even part of sigmoid colon was there, distally enough amount of bowel was there, and that loop we were able to exteriorize.
So what is the advantage over it of that over Hartmann, and what is the advantage of Hartmann?
Hartmann would be preferred in a moribund patient in whom we are not expecting that patient might need another surgery. And even if patient needs another surgery, primary closure after Hartmann surgery is always difficult. Even if we take two separate stoma by laparotomy incision, closure is easier than finding a distal stump of Hartmann and doing a closure.
Lakshman?
If rectum is free, then it is better to do Hartmann's. If rectum is diseased or sigmoid is also diseased, then it is better to take out as a mucus fistula.
Yes.
So
Yes.
whether distal colon is healthy or it is diseased. If it is diseased, then it is better to take out as a mucus fistula or distal stoma. We call it as a mucus fistula rather than stoma.
Stoma. It is a decade. We can bring it together or different places. So that is the one more option. Is there any other option? Still there is an option. Yes. Still two options. Yes.
In this patient, there were no multicentric lesions in other part of the colon. If there had been
So
any,
yes, Julie, just and that was a good point you raised. That is one more reason you should go CECT if possible.
yes,
That
sir.
is a good point taken. Yes. Next. Yes.
Another option could have been a resection of the entire subtotal colectomy with a primary anastomosis and a proximal diverting ileostomy.
Why subtotal colectomy?
If there had been multiple lesions in this patient, I would not do a subtotal colectomy.
Not in this patient. Not in this patient.
Not in.
Okay, any other option? Why not anastomosis with proximal stomy?
Sir, this patient had came in emergency, was kept NPM for 2 days, and patient had intraoperatively grossly distended bowel, and already there was a perforated mass. I would not want to do a primary anastomosis in this case.
What I say is, suppose you do anastomosis with transverse colostome.
That would not relieve the closed loop obstruction.
Why?
Why not?
That
It
would
will-
relieve.
no, no.
Transverse colostomy would relieve, but still there is a chance of leak from the edematous bowel loops. I would not like to do a primary anastomosis.
Okay. Any other reason why you will not do primary anastomosis? One is
So
edematous loop.
vascularity.
Yes. Again, it is important. Distended proximal colon with grossly dilated for a longer time in such a old malignancy where it has already gone into muscle. The chances of healing of anastomosis in emergency condition is very much unlikely. And what will happen? Suppose you do that. That 100% anastomosis will give way and there will be a focus of infection and problems. And in emergency condition, we should not. Is there any possibility of doing post-operative preparation and doing anastomosis?
There, if it depends on the intraoperative, how much bowel loops are dilated. If
There are moderately dilated.
with no perforation, primary
Yes.
with intraoperatively bowel preparation, we can do primary anastomosis.
There was a perforation which was a bad thing. That's right. Okay.
It was also connecting to retroperitoneal surface. Abscess cavity was also there.
So we did this. What do you say, Lakshman? Now it is up. You have to opine.
Yeah, so options are limited in particularly emergency situation where perforation is there. It is
Yes.
a judicious decision to resect it and make a stoma.
Yes. So the point are 2 points are well taken here. One, you should all residents understand that resection is required because there was a one last actually I did not discuss. Simply bring out colostomy. Don't do anything. Julie, don't go away. Still you are here.
I'm here, sir.
Yeah. So suppose you do only colostomy, transverse colostomy, bring it out. Patient's condition is there. It can be justified or not.
Yes, sir. In emergency, we can take.
It is emergency. This is not what more emergency do you want?
Yes, sir. We can do transverse.
So that is a
colostomy.
one option one should keep in mind if patient is totally unstable. You understand? And you have
Yes,
gone
sir.
in, then in such condition, there is a definitely only problem is there was a retroperitoneal collection. That was the issue. But in that case, if patient condition is very poor, you can put a drain there and come out with transverse colostomy. That option, even after the result of this patient, I also consider it a possibility. Could it have been a better or not? Because remember, it was a very advanced mass. In emergency, you did resected, drain it, did a extravasation. So it did take long time and blood loss and everything. So what do you say, Lakshman, about that? That was the one thing I was thinking of, possibility.
Suppose this patient had infiltration of the pancreatic tail, spleen, kidney, and the splenic fracture malignancy with closed loop obstruction. What are the options?
Only one then. Julie?
Still, sir, we have to resect the tumor and the perforated mass. And
No, there is no perforation. There is no perforation.
There is no perforation.
Does the patient has patient is still having obstruction?
Closed loop obstruction.
Closed loop obstruction, yeah.
Sir, I would do a primary resection of the mass and do a proximal ileostomy and give a chemotherapy to the patient post-op.
No. Now you are trapped.
Lakshman, enlighten her now, please. Yes.
So in such situation, this is an emergency. You understand that. and
Yes,
doing a major surgery or undertaking a major surgery, because this patient will need resection of tail of pancreas as well with splenectomy and shaving off from the gerota, or maybe nephrectomy. You never know. So in such situation, it is better to divert and temporize the process while expert facility or help is available. Take it for the next step. Stage surgery is advised.
Yes. So those are the conditions you should understand. There is a possibility of only palliative stoma. Do you understand? Yes. What she is tempted is, because we have been taught colon, irrespective of anything, resection is
debulking.
debulking is it. But in such condition, word is emergency is very important. Understand? We are going to do it, but we will do it some other day. You
Yeah,
understand?
it
Yes.
has to be all, or everything should be available.
Yes. You understand? So that is the trap question. In that condition, because it is not easy to perform such a extra major surgery in emergency in unstable patient. Understand this point. We do not delay it for a very long time, but at least doing a stomy will avoid the further emergency. Patient will be stabilized, and later on you can always do. The question will be, will you do transverse colostomy or ileostomy? Always transverse colostomy in such condition. Why?
Ileostomy will not relieve the closed loop obstruction.
Yes, that is the point, because it will not, colon will not become empty and you can be in trouble long time. So that is that. What will be the disadvantage of doing transverse colostomy in that condition?
For the further procedure, the length of the colon for definite procedure
Yes.
might not be adequate if you do a transverse.
Okay, that is fair enough, but don't worry about that, because
Right.
already the mass is advanced, so you don't worry at that time particularly about further resection. When the time will come, some other expert will do it. We will not do it. Right? So that is the point. Message to be sent is, in circumstances like that, you should always do only colostrum. That are definite indication. Here it was different. It was not invading directly any major organ, and it was retroperitoneally perforated. Still, the second option would have been a possible is doing a stomy and putting a drain. It is if the patient condition is even worse. Again, I am little, because ultimately we lost the patient, Lakshman, actually. So that's why we have kept it. So retrograde, I am seriously thinking would have been better that we have done only transverse colostomy and drainage of the local area.
What I feel personally, there is a delay in the management actually.
Actually, yes, that
Yes,
is the
sir.
point. Yes, agreed. Actually, that is, but we got the patient very late. But still, I was thinking in that line also. But normally we went by the regulation. That means that if there is a perforation, everything, we have to resect it and do extravasation. Actually,
Right.
patient came very late. It was a very badly adherent to all other structure. Even physicians, when they took the patient, it was dead, and we delayed it by 2 days also. It means in a surgery department, he came when we operate in 24 hours, but already civil hospital, it was a delay. But anyway, so you should understand that option is always there, and you should keep it in mind. Okay. Rahul,
Yeah.
next. This was actually yes.
Intro of pictures. There was a deposits of mass over Girota's fascia that was appointed by the artery, and there was a retroperitoneal abscess cavity. This is the colon with the with perforation in posterior wall. Yeah.
Yes.
Post-operative course. The patient was kept in ICU for post-operative period, and patient was extubated, was conscious and oriented, and was maintaining an SpO2 of 100% on 20 mass. Patient was hypotensive from post-op day 1 and was kept on noradrenaline support from post-op day 1, and stoma was dusky and non-functioning. And there was the two drains were kept, retroperitoneal and pelvic drain, which were having serosanguinous output. And RT aspirate initially was bilious, but on post-op day 2, it became fecal. While patient all became tachypnic, and there was persistent hypotension on post-op day 3. And despite of ongoing fluid resuscitation and inotropic support, patient could not be resuscitated, and patient expired on post-op day 3. Biopsy report was suggestive of a moderately differentiated adenocarcinoma, which was infiltrating through muscularis propria and reaching up to subserosal fatty tissue, and lymphovascular invasion was seen. While modified Duke stage B2 was there, and TNM stage T3 N0 with no metastasis, and AJCC prognostic stage group was stage 2A.
So in retrograde, I will agree with Lakshman also. Even Hartman would have been okay. Do you understand, Julie? Why?
Yes, sir.
Right? Then the even operative time would have been a less, and only one stoma would have to be brought out. Lakshman?
Sir,
Hmm.
but here the situation is different. It is not related to the basically surgery. It is
Yes.
related to the derangement of the physiology, which was never restored again.
Restored again. That was the problem. That was the problem. Actually, that's why. But anyway, patient died, so we decided we should discuss it and find out that we could have done
Right.
something different or not.
I think one important thing,
Apurva?
I think the collection and the retroperitoneum was also important, that we were always were a little bent forward to remove it so that the septic foci, even if malignant or not, would have been removed.
Yes, there is definitely, it is there. So, but I think stoma would have not have helped much. That's what I believe. Only stoma. I don't think that we could have helped patient better way.
I
Sir,
think with the yes, beta.
So could we have done a transverse colostomy and after a week or so re-explored again?
See,
But
here the
there was
problem
a
is
The patient was stabilized.
Yes.
There was
Yes.
septic foci. So
Yeah,
patient
even I
you
feel.
have
Dr.
to
Lakshman, what are you saying, sir?
What you were saying, yes.
so I would like to share that if there is a perforation, then it is always better to control the source, because that is the source of infection.
Yes.
And removal of that is important. Whether you remove today or 5 days after, that is important.
But the earlier the better.
Earlier is better. Earlier is better.
Midway.
So the point is that dissection was definitely indicated. Only difference we could have done is only bring out one stoma and close the other stoma to leave for us. Because here the finding would have been easy. It will not be actual Hartman. It will be quite higher up. We would have closed the
Yes.
stoma. That is the point. You understand? It would have been not a true Hartman. Yes, you were saying something, Lakshman?
No, that's fair.
Yes. So do you understand what you said? Close the distal loop. That would have saved some time, and even the stoma would have made it very easily and better. That is the point one should keep in mind. So every time you should not be ready to bring out both ends, as we have been taught that it is always better. So don't worry about one more surgery later on. But yes, that is it could have been a quicker also. So that is, but doing only transverse colostomy, I don't think patient would have improved. That's what I suggested. Transverse colostomy with drain. That's what it won't work. I think patient will not become stabilized. It's unfortunate we lost the patient, but that is the only difference we could have made. What do you say, Lakshman?
I think in perforated patient, it is better to excise the perforated area rather than leaving it inside, because that will be the continuous source of infection.
Yes.
Yes, sir. Yes.
Okay. Okay. I think, would you like to say anything, anybody? So otherwise we'll close it.
Yeah.
Nina,
Nina,
do you
ma'am?
have any question?
No.
You are most welcome to ask.
we are also second case after that.
Okay. Let us start with it. This is again a similar type and different presentation. Siddharth? Yes, he's there.
Good evening, everyone. I'm Siddharth Tandi, second year surgical resident, presenting a surgical audit on a case of closed loop obstruction due to colonic malignancy. Here is the 17-year female patient residing in Kasarwa, Ahmedabad, belonging to lower socioeconomic background, presented on the 12th of June with a complaint of the generalized abdominal distension for last 10 to 15 days. There was a lower abdominal pain for last 10 days and vomiting and constipation for last 3 to 4 days. The patient was relatively asymptomatic before 15 days, and then she developed abdominal distension, which gradually increased over last 2 to 3 days, associated with lower abdominal pain. The pain was colic in nature, gradually increased in severity, diffuse, more over left lower abdomen, no radiating, no aggravating factor, and relieved by medications. The patient is associated with vomiting. Pain is associated with vomiting, bilious in nature, sometimes containing food particle, 3 to 4 episodes per day, and non-projectile, and frequency is reduced by the medication. Patient has not passed stool since last 4 days, and the patient was passing flatus occasionally. There was no history of fever, cough, or weight loss, no history of bleeding PR, melena, and hematemesis, no any medical or surgical illness, no past history of TB, jaundice, or blood transfusion. Patient is taking mixed diet, no addiction, appetite was normal for 4 days, bowel and bladder were unaltered. Since last 4 days, patient developed decreased appetite and constipation. Menarche is
Hello. Can I stop here?
Yeah,
Yes.
sure.
Definitely, most welcome. Definitely.
So this patient has pain abdomen in the lower abdomen, right? And the constipation and vomiting, which is bilious. So what is your differential at this state?
Yes, this is not a Siddharth. This is not a case presentation. There is no need of this all past, personal, family. It is not required. Only salient point you tell us. This is not a master class.
Sir, differential at this point could be the from the history. It could be the fourth abdomen which causing the obstruction. And
Go back one slide. Go back one slide so everybody can see what you are talking. Yes.
So the patient is young patient belonging to lower socioeconomic background. At this point, the probable diagnosis could be a Koch's abdomen. Another diagnosis could be the intussusception, which causes the obstruction.
Mm-hmm. How frequently you see vomiting in intussusception?
Vomiting
that
is
is bilious containing indigested food. That is bilious and containing indigested food, which is 3-4 days old.
Vomiting is rare in case of intussusception.
Okay.
Sir is asking very specific question. From your history, forget about her. What will you think? If I am given choice, I will think it is a small bowel obstruction,
Obviously.
probably proximal. Even probably proximal. More vomiting. Do you understand? More the vomiting, more proximal. Less the vomiting, distal. Do you understand? So from history, how can you put it in the Koch's abdomen?
Age is young.
So young age is Koch's abdomen?
No, sir.
No.
So we can, at young ages, we can rule out the malignancy.
Why? Nobody can rule out. Nobody can rule out.
It may be because
Less likely,
of
sir.
appendicitis.
Sir, less likely.
Maybe because of appendicitis.
Yes, ma'am. It could be because of due to appendicitis, but the pain is localized to the left side of the lower abdomen.
Mm-hmm.
Okay.
No, but why Koch's abdomen? Is there a history of weight loss?
There is no history of weight loss.
How long the patient had a complaint?
Sir, patient has complained of since last 10 to 15 days.
Before that?
Before that, patient has no complaint of
So it is a relatively acute thing. Agreed? Okay. No weight loss. Loss of appetite?
No history of loss of appetite.
Usually if there is a small bowel obstruction and query Koch, you are thinking of stricture or something like that. Where will be the pain?
The pain will be more in the periumbilical region.
Yes, central abdominal pain is a typical of that condition, right? It will be colicky central abdominal pain, right? So pain was colicky. How much it is continuous or intermittent?
So the pain was intermittent. It is not continuous, sir.
So what was the relation of pain with the food?
Sir, there was no relation with food.
Means what do you mean by no relation?
Sir, pain was intermittent, but it is not related with the food intake.
So what were the relieving factor?
Sir, patient has taken some medications from some private practitioner around the near the.
No,
residing.
that is no, that is a treatment chart. You understand? Relieving factor means not medication. What are the aggravating factor and relieving factor? There are actually no aggravating factors. Similarly, what are the relieving factors?
There was no aggravating factor. It means any factor which increases the pain, like taking food or any specific position which causes increase in pain.
If it is a cocked abdomen, what will be the aggravating factor and what will be the relieving factor? What will be the typical pain? Is it related to food or not?
Sir, it would be related with the food intake, and patient pain will be colicky and only centrally placed, periumbilical region.
So how much time after taking food pain will appear?
Sir, after 1 to 2 hours.
Okay. And it will be relieved on its own or sometime after passing a platters or stool. So those were not there. Okay. Lakshman, your question is, I think, not answered, but we will go further, right? But
yeah,
what you said that it looks like a small bowel obstruction.
Yeah, this is what my impression is.
My impression is also, though you have written is a closed loop, my impression it is a small bowel obstruction from history. Go further. Okay.
On examination, patient is afebrile. Pulse is 98 per minute in right radial artery and regular. BP is 118 by 78 mmHg. Right brachial artery in supine position. Sir, abdominal girth is 76 centimeter at umbilical level. So the patient was examined under proper light and exposure.
Anything positive? Tell anything positive. This is not history. Local examination. Local examination. Yes.
Sir, on inspection, the abdomen was distended, umbilical centrally placed, straight transversely. And sir, on palpation, the abdomen is soft, non-tender, no rigidity, no guarding. Liver is palpable 2 centimeter beyond right costal margin and mid clavicular line. And no palpable any other organomegaly, and back and spine was normal. Sir, on the tympanic.
The only important point is auscultation. What were the findings in auscultation?
On auscultation, the bowel sound are present, which were hyperperistaltic.
So what does it mean? What do you mean by hyperperistaltic?
Sir, in bowel sounds are hyperperistaltic because of some obstruction. The
no. What do you mean by hyperperistaltic?
What is the frequency per minute?
Sir, more than 3 to 4 per minute.
That is normal.
There are 3-4 things. One important thing is location. It is all around or in some particular place. What is the per minute frequency and pitch? High pitch, low pitch. That is also important. Do you understand? And one more point, the peristalsis is associated, hyperperistalsis associated with pain or not. Patient can, and when you are hearing of the auscultation, you can correlate with patient's pain also. And sometimes also visible peristalsis, which you have said it is not there. But these are the points in hyperperistalsis you should always see. Okay.
For rectal examination, soap stool was present and ballooning was present. The anal tone was normal and no active bleeding.
Okay.
Sir, at this point, the differential diagnosis could be the small bowel obstruction, obstruction due to interception, and it could be the large bowel volvulus.
Why do you say large bowel volvulus?
Sir, a patient has the complaint of the constipation. And abdomen.
All obstruction will have a constipation.
The patient
has small.
Basically, sir, patient has complaint of distension, which lower abdominal distension.
The point you should understand, this is what we have to find. The 3 differential diagnoses should be related. How will you relate Cox abdomen with large bowel volvulus. You understand? The first thing I would say from your history is all small bowel obstruction. Do you agree with me or not? Apurva? I think yes, one.
No. I'm here, sir. I'm hearing. I see. The thing you need to understand is that you cannot have India, America, and Pakistan just like that. What I mean is, then when you are putting a small bowel obstruction, you have to consider. See, small bowel obstruction is your diagnosis regarding the anatomy. Then you have a pathological diagnosis. So you cannot have a small bowel obstruction and a large bowel obstruction. You understand?
The point is that again you have written Cox abdomen. That also I do. At this stage, I will not put a Cox as a possibility. In India, you can argue that any patient can have a Cox. But here, I would have a possibility is a small bowel obstruction. Because how will you explain both? It can be small bowel as well as large bowel volvulus. So what is the classical? Large bowel means you mean sigmoid volvulus. Am I right? Large bowel volvulus means sigmoid volvulus. Cecal volvulus is there, but it is very rare. So what will be the presentation of sigmoid volvulus or large bowel volvulus?
Presentation with mainly with the lower abdominal pain with distension and constipation, which is acute.
No. What will be the typical presentation? Which patient usually develops?
Distension.
It is a predominantly grotesque distension. You can say that the distension will mask all other symptoms or other signs also. It will be a predominantly distension, and it will be a tympanic all throughout. It may relieve suddenly, occasionally, and with lot of diarrhea. Do you understand? How will you explain vomiting in that?
And mainly in case of the small bowel obstruction. In case of large bowel obstruction, the vomiting is rare.
That's why you have put all three diagnoses. That's what I'm saying. So you should have said at this present scenario, it will be a small bowel obstruction. Madam, would you like to say, because it is your patient?
This is not our patient. This is your patient. And he is prepared.
I don't remember this patient.
Yeah.
No, it is not our patient. Definitely not.
Sir, this patient was from NMP surg unit.
My patient, I will not forget.
Because he told me that this is not our patient.
It was in NMP surg unit.
Okay. But anyway, at present scenario, we will put it as a small bowel obstruction. Lakshman, do you agree with me or not?
Yes, only there was a tympanic sound and left iliac fossa pain, then you can keep it as a large bowel volvulus, but it should be a sigmoid volvulus, not any other else.
And the second is volvulus, maybe the end.
Pain with distension, but it is a 15 days history. In sigmoid volvulus, there will not be a distension for 15 days in most of the case. Patient will reach to the hospital before.
Yes, and it will be a severe distension. It will merit admission very early, and then some measures has been taken. Second, it is a recurrent history will be there in a many sigmoid volvulus. Patient had admission or a pain relieved by this. And vomiting will not be there. And in that sense, bilious vomiting will not be there. Okay. So this is the first. True. So we will at present scenario, we'll put a small bowel obstruction. Yes. Okay, next. What next?
Do we have a, okay. This is,
yes,
okay.
That's fine. Yes.
Fine. RT 500 cc gastric with bile. Okay.
Ice tube number 16 was inserted, and the state out was 500 cc gastric, which was mixed with bile. Periurethral catheterization was done. Patient was advised NBM. Blood investigation was sent, and chest X-ray.
Show us X-ray. Show us X-ray.
Yeah, I'm interested in the X-ray. No, show us the plate.
Plate.
Yes.
Yes. Oh. So what are the findings? X-ray.
On X-ray, multiple dilated bowel loops, as well as small bowel loop, as well as large bowel loop.
So where are the large bowel loops? Where are the large bowel loops?
Here so
bowel loops. Marker.
Yes, he is showing.
Here bowel loops which are having ostrations are suggestive of large bowel loops more on the periphery.
That is yes. That is definitely large bowel. That I agree. Yes. So what does it suggest?
It suggests the obstruction in the large bowel distally, in distal part, mainly in the descending
Why
colon.
not
Because
paralytic ileus? Why
Yes.
not
Yes,
paralytic ileus?
so one
That's
thing,
what.
I think this is more of a gaseous abdomen, what you see in paralytic ileus. See, there are no air fluid levels. Can you see?
yes,
What you are seeing is only gas shadows. Is there any fluid levels?
there is no air fluid levels.
Actually, I talked with him, and there was no X-rays and CCT abdomen was available when they prepared this case.
Mhm.
So only this one X-ray was available on console. So he took this X-ray.
No, fine, that's all right. It is, Siddharth, don't worry. Don't take it personally that
No, no.
we are discussing.
The
This
thing
is
is,
fine.
Yes.
This is for discussion. In this case, patient may have paralytic ileus
Don't worry.
because of the
the point
vomiting and
is,
all these things.
the
But
point
this
is
was
that you should listen. The point is you should compare this X-ray with the X-ray that was shown by Rahul. So you will
this
be
was
able to, see that was air fluid level and this was air shadows.
X-ray supine. X-ray standing was done, but I could not get the X-ray standing. So this is the X-ray supine.
But still, you can say whether it is a paralytic or not. What are other things you are seeing in between? In between loops, do you see anything? So there is a white lines are seen. What does it suggest? You can see in between loops, right? And predominantly gas is there, air fluid is less. That again suggests is unlikely to be paralytic ileus. In that will be absence of fluid will be there, and there will not be this much of a gas shadow all throughout the abdomen, right? And there is left side I don't see, but one thing is very clear: there is no sigmoid volvulus. That is for sure, right? So if it is an obstruction, where is the site of obstruction?
Site of the obstruction could be the distal bowel, distal large bowel.
Why? Do you see transverse colon?
Yes, we can see the transverse colon here.
I have doubts. I am not sure. Though X-ray is not that quality, but I don't see. Ascending, this I can see here. That is for definitely, but I cannot see transverse colon. Remember, if it is a large bowel obstruction on the left side, like in the last X-ray, transverse colon will be distended, and you can see at least lot of gas in transverse colon, which is not seen. But yes, so what is meaning of that gas seen in cecum?
Sir, it means ileocecal valve is competent, and obstruction is causing the closed bowel loop obstruction.
Again, as you say, it is a small bowel dilated loops are competent, then there will not be gas into into the small bowel.
Very simple. Don't get confused. You see gas in cecum means obstruction is beyond that. Do you understand my point? Obstruction is beyond that. And this is definitely not a competent because lot of gas is still there. Do you understand?
Gas is there into the small bowel, so it is incompetent.
Yes. The second point is I don't see transversal. I will put if it is obstruction somewhere in area of ascending colon or hepatic flexor, which will mimic small bowel obstruction also. Lakshman, what do you say? Do you agree with that or not? Many a time it present like this. Do you understand? I don't see anything transverse colon. I see that gas is here up to here. I can see. So probably that will mimic like a small bowel obstruction many times present. Right? Next.
The USG abdomen plus play is done, which was suggestive of the few of the visualized small bowel appears distended and content filled. Largest diameter is 33 mm, and few of the visualized large bowel loop appears distended and content filled. Largest diameter was 60 mm, and there was minimal free fluid in the peritoneal cavity. So the rest of the USG was normal. Patient's HB was 8, WBC count was 8,400. Platelet was 4,68,000. And INR sir, was 3.2. Potassium was 3.2 and sodium was 127. So rest of the RFT and LFT was normal. So 2-point VCV and 4-point FFP was given. So patient was vitally stable. So we went for the CCT abdomen pelvis to find out the cause of the obstruction. So the CCT abdominalis was suggestive of the asymmetrically circumferential heterogeneously enhancing wall thickening noted in the involving proximal descending colon with severe luminal narrowing and proximal dilatation of small and large bowel loops. The length of the stricture was 3.5 centimeter and wall thickness was 9 mm. Perilesional face standing with possible transerosal extension, multiple subcentrometric size lymph node in the central mesentery along mesenteric vessel, largest 18.68 by 6 mm. Suggests the possibility of the malignant stricture in proximal descending colon with acute intestinal obstruction. Sir, at this level, there were options like exploration.
So we do not have any plates, I think.
No, sir, we could not get.
Unfortunately. Okay. Because in X-ray, I could not see actually transverse colon dilated, much of it. Maybe small bowel were overlapping. I don't know. Okay.
So, in case of so what next? We could go for the exploration. We could go for the colonoscopy and biopsy, and colonoscopy and metallic stenting. Sir, we go for the exploration.
Stop. Too many options.
So what do you say?
So what is the difference in this patient and the previous one?
Yeah.
Patient is 17 years old.
Sir, previous patient was 60-year-old. And the patient was vitally unstable. Patient was hypotensive. Sir, this patient is 17-year-old. Malignancy is less likely. In spite of it is shown in the CCT.
No. Other difference, very important difference. We have discussed a lot in last case. If you are present.
Yes.
There was lump in this case.
No, sir, there is no lump in this case.
No perforation.
No perforation.
No extension outside. You understand? Patient came in plan or in emergency?
Came in emergency.
Emergency, but was stable. So now what will you do? Lakshman wants to know that.
So I wanted to emphasize that this is not a closed loop obstruction. That was a closed loop obstruction. That was a real emergency. This is a semi type of emergency.
Semi, exactly. Small bowel are also dilated, so it was not a closed loop obstruction. Agreed. Ileocecal valve was incompetent, and that's why patient had a vomiting, and all small bowel loops were also dilated. Okay. So what is
the risk? What is the risk in closed loop obstruction? Why it is so important? Closed loop obstruction is so important.
Sir, in case of the closed loop obstruction, the bowel become dilated, grossly dilated. So firstly the blood vessel, venous supply would be impaired, and after that the arterial supply will be impaired. So the chances of perforation will be there.
Okay, so here it is not closed loop obstruction, so perforation is less likely, right? You have time to resuscitate this patient rather than rushing to the operation theater. Here you have reasonable time to resuscitate the patient, assess the patient and decide.
So that is a hint. That is a hint. So what will you do?
We should go for the exploration.
Why not diagnosis first? Young patient, very unlikely to have malignancy. Why not colonoscopy now?
Siddharth, answer.
Sir, CCT suggests you malignancy, so there is chances of.
CCT is just an anatomical site or staging investigation, not the diagnostic investigation. Do you think it is a diagnostic?
There is a chances of perforation and bleeding in case of colonoscopy.
Why?
You need to understand the difference between the two patients.
Will you do colonoscopy or not?
We will go for it or not.
Siddharth, understand. That's why we have taken these two type of patients. Don't get biased by peroperative finding, because he is biased by peroperative. I know the peroperative finding, Lakshman. He is biased by that.
I can understand.
So don't worry about that. Understand, this is the point. Patient has come. We need to refine our skill. So forget about what has happened. Think what you will do. That is the audit. It may be right or wrong, comes later on. Actual finding has no value at present scenario, because every time you do this at this stage, you are not knowing. We do it retrograde. That's why we understand that this patient had this thing. But what we are discussing at this stage, we do not have further information. What we have information is 70-year-old female having a obstruction, probably large bowel obstruction, CECT suggestive of descending colon growth, probably, and patient is vitally stable from this finding, right? So what will you do now? Understand this point.
We should go
I
for
do not
colonoscopy.
deny that patient has obstruction, but what you will do?
Go for the colonoscopy and biopsy to rule confirm a diagnosis of malignancy.
So just a point. So understand, for all residents, understand this point. There is a definite role of colonoscopy in this patient, right? Provided abdomen is soft, distended but soft, patient is vitally stable, CECT doesn't show extraluminal extension or perforation, and even cecum is only distended, nothing wrong. And
so what is the
patient,
sorry,
yeah, please.
What is the critical diameter for the cecum?
Yes.
In closed loop obstruction.
Very good. Great question. Yes.
So that you can decide whether this is a real emergency, go ahead. Otherwise, it will rupture.
So it is a 6.
Yes?
So it is the 70 mm diameter.
70
mm, sir.
7 centimeter is normal diameter of the cecum. Normal. It is 12 centimeter for the cecum.
Somebody, I think Nirav has already written, Siddharth. Yes, he has written. Right? So it is 12 to 13 centimeter. When you will say that you will not do anything. So that is the one information you should ask for in CT. You understand? So please tell us what is the diameter of cecum. If it is 12 to 13 centimeter, it is time that you should not waste for colonoscopy, which will make it rupture. Do you understand? That is the point. So here, did they mention diameter? I don't think. But for a future, this is the one point you should ask, right? Did they mention, and go to CT, what did they mention?
So, okay, you did the colonoscopy. There is a polyp in the sigmoid colon and there is a constricting growth in the descending colon. What will you do?
We should take the biopsy from the circumferential growth and do the polypectomy.
Polypectomy, okay. Polypectomy shows high-grade dysplasia and the malignancy in the proximal lesion.
We should go for the staging from the CT scan.
No. Forget about staging. Very typical question. Understand? In context of 17-year-old female. Am I right? My hint is okay. I think.
Yes. First, we go for the neoadjuvant chemotherapy.
Arre bhai. What happened to the first lecture of HNPCC and all those things?
We have. This
He's
is
having
our
already obstruction. It is out of question of giving neoadjuvant.
No. This point is polyp. Why it is important in 70-year-old female?
That is important.
That is very important. Somebody has written something. Julie, I think, has written. So what can it be? I think where is your third year, madam? She can chip in. Swati, are you there?
Yes, sir.
Okay, unmute yourself and answer on his behalf. So, what will you say if the patient, as the Lakshman sir has said, biopsy is taken from the constricting growth, there is a polyp, and polyp show high degree of dysplasia?
So we will suspect familial adenomatous polyposis in this patient.
Okay, and what will you do?
So we will check for any other polyps present in the GI tract.
How will you check that? Because this is a semi-emergency.
The whole GI tract?
So we will do UGI scopy, upper GI scopy.
Okay.
Okay, then? Lakshman, answer him because I think they are. Please.
In such situation, normally what we do full length colonoscopy in all patient of malignancy to rule out synchronous lesion or multicentricity present or not, which is normally present in 3 to 5% of the patient. Okay, but in cases of polyps, the incidence of synchronous lesion will increases high up to 20%. But due to obstruction, your scope will not be negotiated. In that case, you have two options. One is resect it and leave it as stoma to assess the colon at later stage, or you do intraoperative colonoscopy.
Exactly. That's what I was thinking, because the growth is constricting, the scope will not go beyond that, so it is difficult to assess whole colon. So again, you do all the damage control type of surgery, resect that, do the stoma and wait for another day. But you should suspect, the answer is you should always suspect familial polyposis in such condition, and sooner or later, forget about neoadjuvant and that doesn't come here. For familial polyposis.
We are surgeons.
So this is a very good point. Okay. So the next, that is a possibility. What was done now? Go back. So colonoscopy, I would advise in this patient, right? And that will help me because the patient is only 17 years of age. So it will definitely. But no metallic stent. I don't think so. No metallic stent. There is no role of that in this present scenario. Definitely no. Yes. So intraoperative finding, yes.
Finding was a stricture was present at the proximal descending colon. Multiple mesenteric lymph node was present. Perforation was present at the base of the appendix on the cecum. The decision was taken to do left hemicolectomy with the mid part of the transverse colon from mid part of the transverse colon up to the sigmoid colon, and do the resection anastomosis with diverting loop ileostomy with appendicectomy and primary closure of the perforation of the base of the base of the appendix, and with multiple with mesenteric lymph node biopsy. So drain number 32 was kept in the pelvic cavity from the left side of the abdomen, and 2 intra of PCV and 5 point of the FFP were given. So these were the intra of finding. Here the appendix is minimally inflamed. Here is the stricture, and this is the picture after the closure.
So go back. Post-op reward. Okay. So was it all right? Madam, what do you say? So what was done was all right. That's what I would like to discuss. This is what the audit is all about. Because next time, if such patient comes, what to do? That is an important point. Yes.
Sir, the perforation was at the base of appendix.
So what was the reason for perforation?
No.
I think Nirav is there. He was present in surgery. Nirav?
Nirav, are you there?
Yes, sir. Yes.
So just unmute yourself and let us have. Yes, what were the findings?
Sir, there was a extensive dilatation of the large bowel loops that is extending from ileocecal junction up to that stricture part, and that perforation was maybe because of closed loop obstruction. Because there cecum was also, sir, grossly dilated.
So what does it mean?
And sir, it is not just exactly at the base of appendix; it's just beside the appendix, sir, on a base of.
So it was cecal perforation, you mean to say?
Yes, cecal perforation.
Okay.
So what does it mean? What type of perforation it is?
Sir, it may be because of over distension, because of closed loop obstruction, and there may be high pressure inside the lower loop, which cannot be, and secondary to competent ileocecal valve.
So it is known as a stercolic perforation, right?
Yes,
Okay. So what we should do? What are the options? What we did is a different thing.
Yes, sir. Sir, if it is a at a cecal perforation associated with malignancy, then ideally, if we have to check for vascularity of the bowel loop, and if
already perforation, so vascularity was definitely problematic.
Ideally, sir, it should be a subtotal colectomy with then we can go for a subtotal colectomy with ilio descending anastomosis with proximal stoma. That is a one option. And
Lakshman, would you like to say about what we could have done?
Other options?
Yes.
Hello.
Are there options or yes?
Yeah, Dr. Lakshman.
Please.
So in such situation, normally what we do is we do subtotal colectomy.
Yes.
Rather than doing segmental resection and doing the perforation repair and the stoma,
Yes.
because stoma is still to this perforation, which is not going to protect that area.
yes.
That's
How
what
about
Julie said
doing-
in last time. Yes.
Yeah.
That's what I would also do
Patient
with
is
subtotal
young.
colectomy. Yes. Nina Ben, you were saying something?
As patient is young, 17 years old, can we do proximal ileostomy after?
Yeah, that is what I was telling. Is it possible that we can suture the perforation? We can do a radical hemi, left hemi, what they did, and we do a ileostomy.
No. That is why hemi only then. Then the disease will be there. If you will not remove that.
Left hemi.
No, left hemi. So, I mean, we do a radical surgery for the mass, but we keep the ascending colon part, whatever is available, we keep it. We do a primary anastomosis, we close the cecal perforation, and we bring out a ileostomy instead of a colostomy.
Okay, let me answer this partially. There are three, four problems are there. The first problem, circolic perforation has occurred that the colon which will leave behind will have ischemia.
Okay.
If you are going to suture that part of the colon with distal colon, it is 100% going to leak. Second, the circolic perforation means there is a gross dilatation of cecum, so the bowel will not be prepared. So again, it will be very difficult to do anastomosis unless you do peroperative preparation, and I doubt that will be possible. Third, the perforation which you are going to suture is not going to hold, as Lakshman has already said, because that is going to give way and there will be a leak from that area. And later on, only closure of ileostomy will not be sufficient.
Okay.
I think, Lakshman, would you like to add anything? This is what my take is. Nirav, did you understand what we discussed? Nirav?
Yes, sir. Yes, sir.
You understand? So yes, I believe that only ileostomy with a limited resection of left side is incomplete, and the problem will persist. I believe so.
Sir,
I was going to suggest something else. That is, if you do resection and bring out two ends, one transverse colon proximal end, and second is the mucous fistula of the distal sigmoid, as we have discussed in last case.
Yes, sir. Sir, I have one doubt. Sir,
Yeah, speak up.
Please.
Sir, if in this patient, sir, there is a small pinpoint perforation in the cecum without sir any leakage of bowel content in the surrounding peritoneal cavity, then if that small perforation is present, then we should suspect that all of the ascending colon and transverse colon also having not proper vascularity based on that cecal perforation.
It is always a possibility.
Yes,
it is always a possibility. And for any anastomosis, you need good vascularity. There is that. Remember, it has even pinpoint perforation. Why it has given way? It has an automatic perforation that itself suggests there is a definite compromised vascularity. That's what I believe. And if you closely see, the cecum and ascending colon will be grossly dilated, stretched, and there may be some ischemic patch, which has not given way till. You do not wait till the fecal peritonitis develops. It suggests there is a definitely decreased vascularity in that proximal area. One more point is duration of the disease. If it was a long time, it has become now from closed loop, it has given open loop also. So that means it must be a long obstruction for a longer time. That again gives rise to relative ischemia of the bowel, I believe so. So I will not go for a ileostomy in this patient. At the most, there are 2 or 3 things we can do. One is ileostomy as an end loop, and that close that loop or bring it out as a mucous fistula. That is the one thing I think. But I will definitely not do any anastomosis.
Yes, I was saying the same thing, that if you are doing ileostomy, then it should be an ileostomy. You
Yes.
suture the cecum and then re-explore again. And at the time you finalize while closing the ileostomy that you will like to remove that bowel loop. If it is having compromised blood supply, then you can remove that bowel loop what you have kept as a taking chance.
The problem will be, it will be loaded with stool, and to keep it inside for even a 10-12 days, and later on it bursts, there will be a very bad fecal peritonitis and we will not be able to. So taking chance, I would not agree. The point is that it has perforated one place, chances are there. You may have to empty it completely and it will become very messy. So I will remove that part. That is what I believe. Because it is large bowel, you can become little more radical. Second, one more point is, patient is 17-year-old, chances of multicentric malignancy is there. One more point, the later on patient can develop malignancy at the other part of colon, because if the patient is 17 years of age, the chances are there. So segmental resection only I will not do.
Yes, sir. Yes.
That is, if at all, if you want to save it, what you can do is bring out the transverse colon as a one loop and sigmoid as a other loop. That is the second option I will think of. If at all you want to save, but ileostomy will not prevent it. But if you do the transverse colostomy, the possibility is that the cecum will be empty and then you can assess later. That is but on ileostomy as a loop, I will not do it, or even that, because that will be in the very vital part, and later on if you have to compromise whole cecum and ascending colon, vital part of the terminal ileum will also go.
Sir, what about cecostomy in this case?
No, cecostomy is only
No
for theory.
cecostomy in a closed loop obstruction. No cecostomy.
Cecostomy is a very extreme, very poor tolerable surgery patient, and not in routine case. Definitely no. Here the point is not to save more colon. Point is to give a better post-operative chance to the patient. So here your primary aim should not be to save the cecum or the part of colon. How much colon you will save if you want to save? Somebody has asked good question. That is the second, not my first option. But if all you are hell bent on saving the colon, you close the perforation, but the transverse colostomy is brought out, so the pressure over the colon is relieved. Do you understand? That's what Anand somebody has asked. So pressure over the cecum is relieved and colostomy will function. But again, that is not my first option. I would like to remove that bad part. But at all, if you want to remove, that is the other option. One proximal, one is mucous fistula.
So in a young patient, it is better to remove the disease part and then do primary anastomosis rather than taking the chance of doing transverse colostomy. That should be the first priority.
Okay. But I will not do any anastomosis inside in such patient as far as possible. That is what possibility, because what I want to say is, in a patient in whom such a perforation has occurred, is a very stercolic perforation. So it has a given way at one place. That doesn't mean rest of the colon is normal. So doing an anastomosis inside, there will be a problem later. Okay, Apurva, would you like to say anything? Lakshman,
No, I think that is a good discussion regarding when we have.
But at least I'm very sure, I don't, with all due respect to everybody, I will not do any anastomosis inside in this patient. That is for sure.
So we will do a ileostomy and and sigmoidostomy. And sigmoidostomy.
Or mucous fistula. Okay.
Later on,
well taken.
re-exploration and doing the sigmoid anastomosis.
Iliosigmoid anastomosis. Yes.
Lakshman, any input, sir?
No, I think he has gone. He has some emergency.
Okay, fine.
Next
I think, we should conclude.
Yes, next.
Of course, patient was vitally stable. HB was 10.3 and INR was 1.97. Patient started SIPS orally from post-op day 2. On post-op day 1, there was 50 cc serohemorrhagic drain output.
Let it go.
The patient developed fever, persistent more than 102 degree Fahrenheit from post-op day 3. So dengue, chikungunya and peripheral smear for MP was negative. And sir, a patient has minimal discharge from midline wound, so the swab CS was sent and antibiotic was started accordingly. The fever resolved on post-op day 5 and drain removed on post-op day 5. Sir, biopsy is suggestive of the section from the stricturous growth, so is the moderately differentiated adenocarcinoma infiltrating into subserosal tissue, and extravasated mucin is also seen. The lymphovascular and perineal invasion is seen. Section from both proximal and distal surgical dissection margins shows the normal histology and are free from tumor. The lymph node shows the chronic non-specific lymphadenitis and no evidence of metastasis. The appendix, the specimen labeled as appendix, shows the histology of chronic appendicitis.
Okay.
Sir, the conclusion, moderately differentiated adenocarcinoma of descending colon, modified Duke score, Duke stage, stage B2, TNM stage T3, N0, no metastasis, and AGCC
Great.
prognostic stage group suggestive of stage 2A disease.
Okay.
Good biopsy.
Sir, patient was discharged on post-op day 7. Patient was taking all food orally and stomach was well functioning. Patient came for follow-up on post-op day 12, where all the stitch was removed and wound was healthy.
So all discussion, patient is alive. So what does it mean? What is meaning of it? Do not understand that. That is what it is. We are discussing theory. Practical may be different. So why this patient was good?
So the patient is young and carcinoma is.
So no, patient is young and it's better. So that is the main reason you should keep mind. That is the one point you should keep in a discussion. If patient young, healthy, without any comorbidity, anything you do, patient may be better, right? But the same patient at 60 years of age, chances are very poor. Do you understand? That is the point you should also understand. Okay, anybody would like to ask anything? I think we should conclude. Apurva?
Yes, sir. Yes, sir. We should conclude.
Okay.
Excellent. Really, we enjoyed it.
Okay. I think that
Okay,
should be
fine.
it. Madam, you want to say something?
No.
Okay,
Okay,
Siddharth,
ma'am.
you did good presentation. It's okay, I can understand. Because remember, the one point is very clear. There can be more than one treatment for all such cases. It is at the time of surgery you decide. But when you discuss this, when actual time comes, you can understand. Somebody has very validly raised the point that if you do colonoscopy and wait for a biopsy, it will be too late. Yes, that is the point. I also answered that if patient is in acute obstruction, nothing doing, CT is at the most you can do. These were the only point where patient has a subacute obstruction, which is appearing and relieving. Then there is a role of colonoscopy. Otherwise, definitely after CT, surgery.
You can take brush cytology also just for confirmation if patient is young in a subacute obstruction. Brush cytology is also having some.
But the point is that subacute,
subacute obstruction, not in
Nothing.
acute.
Yeah, nothing doing.
Okay.
Yes, sir.
Okay.
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 Thank you, sir. Thank you, ma'am.
Thank
Okay,
you.
ma'am.
Okay.